Treatment of acute abscess. The treatment of acute abscess, like clinical picture, we divide this patient before suppuration and after suppuration. Before suppuration, rest and analgesics to relieve pain, plus kill the microorganism by proper type of antibiotic and the proper dose, plus local heat to allow excess blood comes to the infected area, and this blood comes with excess leukocytes to fight the microorganism and antibiotic to kill the organism. After suppuration in superficial abscess, incision and drainage is the rule. First of all, anesthesia or anesthesia. Anesthesia usually in drainage of acute abscess, field block anesthesia by infiltration of local anesthetic agent around the abscess in the healthy tissue. Inject in the surrounding healthy tissue. Field block injection and infiltration of local anesthetic around and under the tissues, and the tissues under the abscess. But the environment of the abscess is acidic, which may cause local anesthetic to lose its effect. Therefore, we should infiltrate proper dose of local anesthetic agent and wait for a while until the local anesthetic gives its effect. General anesthesia may be used in sensitive patients, children and women, because most women are very sensitive. After anesthesia, incision. The incision should be long as possible and over the pointing part. This area is the pointing part, and the incision done over the pointing part of the abscess. And the incision should be dependent, i.e. in the bottom of the abscess, in the lowest point of the abscess, to allow proper drainage. And if you do incision and the incision is not in the dependent part of the abscess, this requires counter incision. Counter incision, example in this breast abscess. If you do incision here and when you enter your finger inside the abscess to divide all loculi and drain all pus, your finger enter below this point. Therefore, we perform counter incision. Counter incision in area corresponding to the first incision. If you do incision here and you discover that this is a not dependent area, therefore we perform a counter incision in the under surface of the breast corresponding to this point. As a rule, never cross a skin crease, because skin creases are opposite joints, and if you perform incision cross to the skin crease, in the future fibrosis occur, and this fibrosis prevent full movement of the joint and leading to limitation of movement. Therefore, the incision should be done parallel to skin crease or away from the skin crease. Sure, the incision should be parallel to important structures. Parallel to important structures like radial incision, parallel to lactiferous duct in breast abscess, or in deep incision. Deep incision in the parotid gland should be transversely parallel to the branches of facial nerve. We take before parotid abscess, and we all know that we will divide the skin only vertically. But in the depths, we should open the abscess horizontally to avoid injury of branches of parotid nerve, facial nerve. In dangerous area like parotid region, we open the abscess by separation of tissue, not division of the tissue. How? By Hilton's method. What is Hilton's method? In important area like parotid abscess, we open the skin only. And important area like parotid, neck, or axilla, we open the skin only. Then enter the abscess by closed bleeds of artery or sinus forceps. Enter with closed bleeds. Then open the bleeds widely to separate the tissue and to allow free drainage. This division by separation of tissue, not division of the tissue, to avoid, example in the parotid salivary gland, avoid injury of facial nerve. And after incision, your finger or curved forceps is introduced into the abscess cavity and to divide all septa and open any loculi to allow drainage of all pus by finger if large cavity, or in a small abscess cavity by curved artery forceps. Divide septa, open loculi to drain pus. Finally, backing the cavity by gauze or insertion of rubber drain into the abscess. Backing or insertion of rubber drain is essential for better drainage. Any pus formed in the few following days should be drained to outside through backing or the drain. Remove the back material and reback every 1 to 2 days until the abscess cavity completely resolve and the backing material can no longer be inserted into the abscess cavity. Later on, after we finish from drain or backing, dress the wound without backing until complete healing. Post-operative antibiotic for immunocompromised patient and severe infections. Therefore, if usually in most abscesses, incision and drainage is enough. But if there is immunocompromised patient or severe infection, antibiotic post-operatively can be done. This is incision and drainage, which is the usual treatment for superficial abscess. But in deep abscess, like intraperitoneal, intra-abdominal abscess, what is the treatment? As we take before, the treatment is usually ultrasonic or CT scan guided aspiration. If there is chronic abscess, if there is chronicity and the chronic abscess is discovered, if the abscess has thin wall, the treatment is acute abscess, incision and drainage. But if has thick fibrous wall, it is treated as any lump with excision. We should notice that no incision and drainage in abscess in certain sites. No incision and drainage in amoebic liver abscess, brain abscess, lung abscess, or cold abscess due to TB. And we should remember that fluctuation is very late, and never wait for pointing and fluctuation in breast abscess, parotid abscess, perianal and perineal abscess, hand or Ludwig angina. To remember these sites, take from above downward. In parotid abscess, in Ludwig angina, in breast abscess, in hand infections, and below prostate, perineal, and perianal abscesses. This is a treatment of acute abscess. Thank you for good listening and good luck.